I'm Gemma, welcome to my channel. So today I'm going to be talking about schizophrenia and why it is such a contentious diagnosis, why there are campaigns to get rid of it, what's wrong with it, and we're going to do a little bit of history on it and talk about some potential alternatives to the diagnosis. So a little bit about me, because this is my first video. So I did a psychology degree in Durham, that was back in 2013, and I did a master's in clinical and health psychology at Newcastle University, and I'm currently working within the research team at a trust in Cumbria, and we're doing a paper on IAPT, which is increasing access to psychological therapies. So that's a little bit about what I'm working on at the moment and a little bit about my background. So schizophrenia, so why is there an issue with this? Well, ultimately we don't really have a good prognosis in this country for schizophrenia. Actually what they've found, what the World Health Organization has found, is that the prognosis for schizophrenia is better in developing countries than it is in developed countries. So there really is some kind of issue going on about how we use the term, how we diagnose people and how we treat people in this country with that disorder. Just so you're aware, I will try and include all the references that I use on the screen and in the description box below, and the vast majority of what I'm going to say today is backed up by references. A lot of them are from the anti-psychiatry movement. So, you know, they weren't very subtle about their beliefs. They're very passionate, and so, you know, if you disagree with anything, please let me know in the comments, or, you know, I'm always happy to consider alternative perspectives. So, oh, and similarly, if you think that I've made any mistakes or anything that I've said you don't necessarily agree with, similarly, please do let me know. Okay, so let's talk a little bit about the standard kind of diagnosis of schizophrenia. So if we look at the DSM-5, I think is the most recent one, back in 2013. If we look at the most recent kind of diagnostic criteria, we have our positive and our negative symptoms. So positive, we have hallucinations, delusions, disorganized thoughts, and disorganized behaviour, and catatonia, which we don't really see that much anymore. Some people think that might be linked to the medication that we use now. Some people think that catatonia was the result of encephalitis lethargica, the pandemic that we had many decades ago. Who knows? Well, we don't really see that anymore, but it is still included in the diagnostic criteria, and you only need 2 positive symptoms to get the diagnosis. The negative symptoms are what I like to call the 5 A's. We've got flattening affect, which is obviously emotion. We've got avolia, which is motivation, lack of motivation. We've got asocial, so obviously not feeling very sociable. Alogia, an inability to articulate or hold a conversation, and we've got anhedonia, which is lack of pleasure. So they're the 5 A's. Some people think that the negative symptoms that we have of schizophrenia are linked to the antidopaminergic medications that we have, that we treat people with, which kind of makes sense a little bit if you think about it, because dopamine is a neurotransmitter that is linked to pleasure, it's linked to motivation, to focus, to that kind of wanting sensation. So that does make sense, but I'm not really going to go into that today. That's kind of a whole other video. So I've talked a little bit about kind of the standard diagnostic criteria for schizophrenia. Let's talk a little bit about why that might not necessarily work and why there are kind of arguments against it. I mean, predominantly it is very heterogeneous. So there are so many people that have that diagnosis, and their clinical presentation looks different in every single case because it's so variable. And many researchers argue that the symptoms that you see with disorders like schizophrenia should actually be on a scale. So, it shouldn't be that you just get the diagnosis or you don't have the diagnosis. And often people, when they get the diagnosis, they're stuck with it for life as well, which is damaging ultimately, And that was part of I think it's called the CASL campaign, CASL campaign against schizophrenia label, which came out in 2007 by Manchester University, and it is what it says on the tin, but that was one of their main kind of statements, was that the schizophrenia label is damaging to the people that receive it and also to the clinical treatment process. And they also argued that it was unscientific and that it caused stigma against this group, and we do see this is probably the most heavily stigmatized group out of all the different psychiatric diagnoses. So going back to what I was saying, so lots of people think that actually the symptoms that you have with schizophrenia could be perceived as to be on a scale, and it could be that actually people just have this symptom or they just have this symptom, and it's not necessarily disordered or abnormal. For instance, there was a 15-year longitudinal study that found that 10% of the population have experienced a hallucination or a delusion, which is quite interesting. We also have instances where sleep deprivation can lead to what's called a hypnagogic state, which is where people hallucinate and see and hear things that aren't there. We know that sleep deprivation as well is also a precursor to postpartum psychosis. There's a lot of documentaries about that. There's a one Louis Theroux did on women and their psychotic experiences after giving birth, and if you watch them you'll see that a lot of them are related to a traumatic birth, and there is sleep deprivation involved in that. We also know that states of sleep deprivation are common before a psychotic breakdown. There are some studies where they've looked at the level of psychosis and insomnia, and there's very positive correlation there as well. And there's also things like alcohol withdrawal and temporal lobe epilepsy, which cause hallucinations. So really kind of why I'm saying this is, people have to acknowledge that there are instances where people have hallucinations and delusions that wouldn't be classed as schizophrenia. So, why we are using this diagnostic umbrella term, if we were to diagnose everyone who had a hallucination or delusion as schizophrenia, then God knows how many people we would have. Consider how damaging schizophrenia, that label, can have on people's lives, and how when people are diagnosed with it, they never seem to get rid of it. You can say that perhaps because some of these symptoms occur in the normal general population, that we could be over pathologizing normal responses to trauma. So that's kind of that. What needs to be kind of mentioned, the most important point here about the label schizophrenia, is how old the concept is. There are lots of theorists, lots of psychologists that kind of acknowledge how the way the DSM and the ICD, the way they have the diagnostic criteria is what we call neo-Kraepelinian. It's quite difficult to say that. Neo-Kraepelinian. So Kraepelin was around over 100 years ago. He was a researcher who basically, he's known for his what's called dementia praecox syndrome, and he theorized that that was a distinct syndrome to manic depression. So he defined them as very distinct disorders, which is what we call Kraepelin's dichotomy. And this is what still stands today. So, obviously schizophrenia and bipolar, they're classed as two very distinct disorders. They're diagnosed differently, and they have a different set of diagnostic criteria. So this is Kraepelin's dichotomy. This is his principle, which was founded 1896. And the only distinguishing factor, really, that he said between the two disorders was the prognosis. And that's that dementia praecox syndrome, which is what we would now refer to as schizophrenia, lasted a lot longer than manic depression, lasted 6 months or longer. So when he came out with this theory, basically they just waited for people's symptoms to see if they would change, get any better. If they didn't, then they'd get the dementia praecox diagnosis. If they did, then they would get the manic depression diagnosis, which is what we now refer to as bipolar disorder. So, I mean, if you look at kind of the similarities, you can really see the archaic nature of the diagnosis and how it really does need to be updated. We still have that dichotomy in the DSM and the ICD. Also, there are some researchers such as Taylor and Shorter that highlight how the DSM still implicitly accepts what's called Schneiders first rank symptoms. So Schneider was a researcher back in 1939. He identified what could be termed schizophrenia and the group of symptoms that underlie this disorder. So it's basically very anecdotal. He was in a hospital, he was walking around, he was making notes on all these psychiatric patients. I think there was about 166, so it wasn't a huge sample, and he kind of made notes of symptoms that kind of popped up quite a lot, and he kind of grouped these people together, and he said these all had what we call first rank symptoms. So these people must have schizophrenia, and we can use this as this group of symptoms to identify additional people with this disorder. So it's quite similar to what we have today. So what he said was hearing voices, arguing, commentating, thought inferences, delusions, impulses, movements out of control, and thought withdrawal and insertion. So those are kind of the symptoms he identified, and he grouped patients into people who did and people who didn't have these symptoms. People who did, he gave the diagnosis of schizophrenia. What's quite important to recognise is that no individual symptom was found in the majority of participants. Thought disorder was the most prevalent, but that was only in 21% of the patients. So, it's not exactly it's not exactly a distinct syndrome that he identified, really. And additionally, because of the timing of this, there are a lot of theorists that actually think that some of his first rank symptoms were actually the result of encephalitis lethargica, which was a bit of a pandemic at the time. There's a really interesting podcast called This Podcast Will Kill You, and they do a podcast on encephalitis lethargica if you want to learn a bit more about that. It's really, really interesting. And a lot of the symptoms people had with that kind of involved muscle stiffness, somatic passivity, so people could be moved into different positions by the doctors, by the nurses, and they would remain there for long periods of time. So, I mean, this was part of Schneider's first rank symptoms, but who knows, this could have been encephalitis lethargica. There are lots of studies out there disputing Schneider's first rank symptoms, and in particular disputing kind of how that distinguishes schizophrenia and bipolar. For instance, there was a study it's quite old, it's about over 20 years ago now, but it was 660 participants who had a full spectrum of functional psychotic disorders, so bipolar, schizophrenia, and lots of other schizoaffective disorders, that kind of thing, in the middle. And basically they all experienced, to some extent, Schneider's first rank symptoms, which indicates that his so-called schizophrenia symptoms aren't just definitive of schizophrenia, but could also be seen in other disorders as well. So take a look at the literature on that. It is very heavily criticised, and it wasn't really founded on that many patients at all, and he didn't really use very scientific methods in his recognition of those symptoms at all. It was very anecdotal, it was very phenomenological, it wasn't very scientific. So why should we change this diagnostic label, schizophrenia? Well, as I've talked about, it's very heterogeneous. No two people can appear the same with this disorder. There are so many symptoms and so many different variations. It's very, very vague. And based upon the diagnostic criteria that we have, you can't make any predictions about someone's prognosis. The prognosis really doesn't look good, particularly in this country. You can't really make many predictions about the etiology. There are lots of different theories out there, but you can't really make any clear predictions from just looking at the DSM and the ICD criteria. And if you look at how the label's been used historically, I mean, the amount of stigma that it's created, the amount of people that have had the diagnosis and just had to stick with it forever. If you look at the psychodynamic movement in the 1940s, these large institutions with psychiatric patients in them, everyone had the diagnosis of schizophrenia. Everyone. And that just goes to show, how vague it is, how easy it is to give someone the diagnosis, because you just have to have two of all these above to get it. So it's very heterogeneous. It's also, based upon the research that we have, there are lots of similarities between schizophrenia and bipolar, which it calls into question Kraepelin's dichotomy. It calls into question, whether they should be classed as two distinct disorders, and why. If you look at that overlap, particularly what you have is thought disorder is massive in both disorders. You've also got the same rate of comorbid anxiety. They're both medicated very similarly. Nowadays it tends to be a lot of these mood stabilizers, such as olanzapine. The term mood stabilizer is contentious in itself, because there are some theories that that's been completely confabulated by the pharmaceutical industry. So, they're both medicated very similarly. I mean, what does that tell us, really? There are also some theorists who suggest that there might be some distinct disorders that exist within the umbrella term schizophrenia. For instance, Charlton's theorised that there could be a delusional disorder, which is based upon our implicit and evolutionarily formed ability to make social inferences about other people. So, the theory of mind module in the brain, that's what it's called, and it's that ability to make inferences about someone's behaviour, someone's judgment about other people. And he basically thinks that delusional disorder is caused by people making incorrect inferences or beliefs about other people, and that spiralling and getting out of control. And it makes sense if you think about it, how that could snowball into having a bias into picking up on certain things and cues in the environment, and that confirming your beliefs and that kind of snowballing. So he thinks this delusional disorder could exist within schizophrenia, within a group of these people who have a schizophrenia diagnosis, which, as you can imagine, is probably needs to be treated very differently to the people who have very bizarre delusions that aren't necessarily socially orientated, very bizarre kind of thoughts, that kind of thing, which might not necessarily be caused by their theory of mind module, but might just be caused by brain pathology. And so, that's his kind of theory, is there's a distinction between those disorders, bizarre delusions, and our theory of mind inferences, and that they should be treated very differently, whereas everyone who gets the diagnosis schizophrenia is probably on the same course of medication. So why hasn't it changed? Even though, I mentioned about the campaign at the beginning, there's been campaigns against it, it's still clinically used. I go out onto the wards to do my research. I hear it all the time. People still get diagnosed with it. Why? Well, one of the things that's kind of discussed is that it's quite a simple and attractive term, because it's less kind of complicated if you can kind of just label someone as having this and then kind of crack on with the treatment. Some kind of psychologists say that it could be linked to the pharmaceutical industry and their hold on how we categorize and how we define psychiatric disorders. If you think about it, they are very kind of powerful, and they fund a lot of our psychological research and a lot of our medication research, and so they kind of would need to cooperate if we were going to make a shift in renaming or relabeling this disorder. And would that benefit them? Who knows? So, I mean, and in addition to this, it probably hasn't changed, because if you think about it, it's probably going to be a heck of an operation to do that. It's to shake up our whole diagnostic system. I mean, that's been standing for over 100 years. It's gonna be one heck of a project. So, I mean, that's probably another reason. So, to talk about some alternatives very briefly to the schizophrenia label that hopefully will be more widely used in the future, we have some researchers who really advocate for use of different terms. We have, for instance, Taylor and Short, I believe, the term hebephrenia, which was initially coined by Hecker in 1871, so it really is quite an old label. They say that that's far more helpful because it's a much more specific syndrome, and it mainly focuses on thought disorder. So that could be a potential alternative. There's a lot of researchers that advocate for a psychosis spectrum, which would help in kind of getting rid of this schizophrenia and bipolar distinction, this affective versus non-affective psychosis distinction that we have currently in the diagnostic manuals. So, the spectrum would include all kind of symptoms that we see, and it would include non-affective and affective symptoms as well on there. Again, there's a really, really good paper on this. It's a really, really good literature review by Angst. So take a look, and this would solve our issue in terms of the Kraepelinian dichotomy. In addition, some researchers also say that if we just use a symptomatic approach, this would be so much more easier to treat than to lump everyone into this heterogeneous diagnostic category. And, that's kind of where I would stand as well. If you think about it, medications treat certain sensations in the body, and if someone is feeling slightly X, slightly Y, slightly Z, you know, there are certain medications they can have for that. And if you think about how every person who has schizophrenia, their medical presentation is so different in terms of the sensations, in terms of their subjective experience. If they were to say, well, on a scale of 10, I'm experiencing 7 in my low mood, I'm experiencing 5 in terms of my thought projection. You know, I know it's difficult because people with those kind of disorders don't necessarily have a huge amount of insight into their illness, but I do think that's probably the right direction we can go in terms of treating this disorder and helping the prognosis and eliminating some of the stigma that kind of goes with it. I also think we need to look at kind of other cultures and what is working for them and why it isn't working for us, which I think is ultimately going to bring us back to our medicalisation. And I'm not saying I'm against psychiatric medication. All I'm saying is, you know, we need to be examining what we're doing and looking at why we have such a poor prognosis in this country. Okay, so that's everything that I wanted to talk about today. Really keen to hear your thoughts, your comments. Please comment below, and I'll put all the references in the description below as well.